it's the more chronic cases, the longer standing cases, where the extended cultures are so beneficial in giving us some idea of what is there.
We also received quite a few questions about UTI testing, and you've recently set up your own diagnostics lab for this purpose. Can you explain why you no longer rely on standard urine culture?
Yes, absolutely. Standard urine culture is based on a very old-fashioned criterion. There was a study back in 1956 by Kass et al. That looked at a small number of pregnant women with kidney infections. And really, this study was aimed at trying to prevent pregnancy loss. And the objective that Kass and his co-workers had was to establish at what level of bacteria in the urine causing a kidney infection does a pregnancy become non-viable. And so it was a small study. It was a cohort of pregnant women, and there was a line drawn in the sand for a very delineated outcome. And that line in the sand was drawn at 100,000 bacteria per milliliter of urine, so 10 to the 5 per milliliter of urine. But prior to that, there had been absolutely no threshold. And I would stress that this was adopted really just in the Western world. This was used, and in the early 80s, in 1981 actually, there was a further publication by Stamm et al. And Stamm et al. Said, hang on. This isn't good enough for some of the patients. We're applying this standard, which was really only applicable to kidney infections in pregnant women, across the board to all patients. And we really need to look at the patients who are symptomatic with lower counts of infection down at 10 to the 4, 10 to the 3, because we may be missing them and telling them that they are not infected, because the reports come back from the laboratory saying no significant infection. And no significant infection, I can tell you from working with my colleagues and teaching on this area, that the clinicians think that no significant infection means no infection, and it doesn't. It just means that it hasn't reached the threshold, hasn't hit that Kass criterion. Now, unfortunately, Stamm didn't manage to overturn thinking on this. And because it was already entrenched and in protocol in the majority of laboratories throughout the Western world, they just carried on. And to this day, we still use this more than 10 to the 4, usually 10 to the 5 cutoff. And actually nowadays, I mean, certainly in the UK, in large NHS testing laboratories, we have a system whereby urine samples go through something called particulate recognition. And we measure the number of pus cells. We measure the number of red blood cells. We measure the number of bacteria per microliter. So that's a thousandth, I can't say it, thousandths of a milliliter. And if it doesn't hit a threshold, that sample isn't even cultured, it's just binned. And yet we know that the majority of patients with recurrent and chronic UTI are never going to hit that criteria. Additionally, it doesn't take account of the fact that quite often patients with urinary tract infections will find relief from drinking extra fluids and diluting their urine, making their urine less acidic, more tolerable, rinsing out the bacteria, therefore over-diluting their urine. And therefore it stands to reason that these bacteria and these pus cells and these red cells are going to be further spaced out in the urine by a dilution effect. And this is totally not taken into account. If they were to do things accurately, they would take a marker such as creatinine, which is a waste product, which is excreted into the urine, and they would calibrate the number of bacteria against the creatinine concentration to actually get a real reading on how many bacteria per unit that there are. This isn't done, and unfortunately 10 to the 5 would still be inappropriate, even if it was an averagely concentrated urine. What we do differently is something that has been used for a very, very long time and is used in certain circumstances, for example, for bloodborne infections, and that is extended quantitative culture of urine. And in extended quantitative culture, yes, we use the standard agar plates, but we also seed into liquid broth cultures. It's very important when we do this to make sure that it's an incredibly clean catch midstream urine specimen. To do this, we provide the patients with quite a lot of instruction. So we do appreciate them gritting their teeth when they get out of bed in the morning and giving themselves a bit of a wash down below. We also ask for the women to actually tamponade the vagina. So because we know that when women pee, that they do pass some vaginal exudate into their pee with their urine stream. And so if they can get something like a water wipe or a baby wipe that's been well rinsed out under a warm running tap, ball it up, pop it a couple of centimeters up into their vagina before they have their wash with a shower hose from front to back. And then they don't even need to get out of the shower. They can take their bottle into the shower, start peeing, bring the bottle into the midstream, take it back out before the pee stream's finished, lid on, name on, date of birth, and send off. But before they send off, we also like the second pee of the day, because we know that the agitation that the first pee of the day has created on the bladder has made any of the slightly loose bladder cells that we're shedding, because the bladder knows that it's got embedded infection and it has failed to eradicate it with its own immune defense mechanism. So it says, hey, let's sacrifice these cells that are infected. Let's get rid of them. So they're sort of hanging by a thread. And that first pee of the day really pulls that thread a little bit more. So they come out with the second pee of the day. So invariably, we find with chronic and very badly recurrent UTIs, the first pee of the day has the highest concentration of bacteria in it. And the second pee of the day has the highest concentration of shed bladder lining cells. And we take both these specimens and we look at them both in detail. Yes, chemical analysis, yes, microscopy, but also we culture from both of them. And we enumerate the number of bacterial colonies on the agars below that 10 to the 5 cutoff. So we will take it down to even below 100 colonies per milliliter of urine. But we will also look at what grows in the samples that we have seeded into the liquid broth extraction cultures. And we have to bear in mind that we cannot enumerate these because it is an exponential growth culture. But it gives us an idea of what is hanging around in small numbers and can, woof, like a forest fire, come up and create a problem. You know, it can give us an idea of the little zoo that's living in that patient's bladder, that they may have presented with an E. coli and an enterococcus, but back in the background, they've got a Klebsiella or a Proteus. And I have to think this patient's done a very carefully caught specimen. This is a potential pathogen for another flare-up. And it could be a flare-up 2 days later, who knows? These bugs can grow incredibly quickly once they manage to get into planktonic exponential growth phase. And just to validate that, when we first started out with this, this clinic, looking in depth to these patients, we had some local patients that we asked to produce urine samples before they came to the clinic. And then when they were at the clinic, they gave permission for a very clean, very small catheter to be inserted. So we got a catheter sample of urine and we looked at those patients with their cultures side by side and found that we were finding exactly the same organisms. So we know that a very carefully collected midstream urine specimen is actually as good as a catheter collected specimen in our experience.
Okay. We did get a few questions about how to collect a sample, so that's really helpful information. Are you finding that the expanded culture that you're using is actually identifying more organisms than the standard culture did?
Absolutely, we do. Absolutely. Yeah. We find that the standard culture is appropriate for some. And again, it's the more chronic cases, the longer standing cases, where the extended cultures are so beneficial in giving us some idea of what is there. And once we've managed to identify what I call almost like the background organisms, the trace level organisms, we know what all the usual culprits are, and we can see, we run a panel of 11 different antibiotics against them, and we can recognize in when a patient resubmits, they quite often, when patients have sampled through us, they like our service, they come back again because they have come up negative time and again in their usual labs. We say to them, well, we found 3 different organisms, and they're almost sort of like shocked by the fact that after dozens and dozens of tests, they've suddenly found a lab. I have so many patients in tears, actually, that they feel validated at last.
Definitely.
They knew their symptoms were telling them that something was wrong, and yet the clinicians they'd been seeing were saying, sorry, nothing's showing it, this is all in your head, or you're sure it's not your bowel, and I'm sorry.
Yeah, we hear that a lot. Does expander culture also pick up fungal infection? And do you think that could be an issue for some people with chronic UTI?
Right, okay. So fungal infections, yes, we will find, especially we find yeast, we find candida infections quite frequently amongst these patients, because it seems that recurrent UTI and candida go hand in hand, possibly because of the repeated antibiotic use. And of course, we will treat accordingly if we find this. Whether it can be candida causing the issue, well, I certainly think that a patient is very reliable in knowing whether their symptoms are bladder or external. Now, if their symptoms seem to be very much urethral and vulval, possibly vaginal, it is something definitely to be taken into account. And bearing that in mind, we also do process swabs. So, if a patient is, at consultation, we feel this is, we invite them to process a swab as well, just to see if we've got that. And we've got to bear in mind that when we see thrush candida in the urine specimen, it could well have been of vaginal origin. So we always validate that. So it's incredibly unusual to get thrush infection in the bladder. And we normally only see that in immunocompromised patients and patients on renal dialysis.
Okay. For people that seem to experience UTIs after sex with a specific partner, do you think it's worth having the partner tested to see if they're transferring organisms?
I'm glad you've mentioned that. And wow, you're ahead of the game, because this is something we've only just started doing recently. And boy, oh boy, it's fascinating. I'm so lucky. I've got such an interesting job, and so lucky I've got my own lab that whenever something pops up like this, I think, oh, I want to have a look at that. I can go down that track. And yes, we are finding that quite a bit. And because we test 11 different antibiotics, it produces a specific footprint for a blueprint for an organism. It tells us, when an organism's got 6 antibiotic sensitivities and 5 different resistances, and you find another organism in her partner from a swab taken up from under the foreskin is exactly the same organism, exactly the same footprint, there's no mistaking that's the same organism. Also, we run a load of biochemical tests which validate it down to a subspecies level. So basically, yeah, it's incredibly useful.
It's really good to hear that, because patients do get a lot of pushback about wanting to have a partner tested when it really seems specific to that partner. And does that mean that you're also then providing treatment for the partner?
Yes, we can do, but the treatment for the partner is usually quite different. So we don't provide antibiotics like we're providing for the lady, for the partners that want to receive treatment, because obviously these partners are usually not symptomatic, and if they do not want treatment, we cannot, we can offer if they want to, but normally they do want to. We normally recommend use of just a topical cream that basically it can be an antiseptic wash or an antiseptic cream, because they don't need antibiotics. This is external. They can have a good wash with something that actually will kill the bugs.
Right.
you know, we've got to bear in mind that if these patients are asking, especially in the UK, if they are asking their NHS doctor, it's pointless, absolutely pointless, because NHS labs will not report. You know, a woman can be ill with awful bugs. You know, she could have Pseudomonas, Klebsiella, Morganella, Proteus, E. coli in her bladder. And if all those bugs are found under his foreskin, they will not even be reported on an NHS report because they are not regarded as a reportable infection. So what you'd find, you know, really, we're only looking for sexually transmitted type infections,
right,
in this cohort. So they don't actually meet with the guidelines for reporting.
Given that is a problem, is it possible for other doctors to access testing via your lab?
Absolutely it is. And we are finding more and more of this. So patients can go to their GP and they can say, I know that we can't get this done through the NHS, but you know, Dr. Anderson has this lab that can do this testing, and she can, you know, provide support for any doctors that want support. We are always writing advisories to GPs, and we're getting some great results through that. It's variable how supportive the GPs are of going through this mechanism. Some GPs are just wholly relieved, actually, they're going to be able to bring their patients some relief and attack this. Other GPs just don't want to engage. The patients have an uphill battle. It's such a shame that it's up to these poor suffering patients that they have to find themselves a GP who is so invested in getting their patients better that they will actually think outside the box and say, yeah, let's go to a private provider that provides something a little bit more comprehensive than is available routinely.
A lot of the onus does fall on patients that have this problem. Is it possible that in the future your testing might be available via the NHS?
I would love if that was the case. And we would love to be commissioned back into the NHS. I would love just to change the way the NHS approaches these type of patients. I've said time and again that I would like to recommend that patients are identified when they have recurrent or chronic problems, and they are flagged as named patients that need this additional testing doing and things taken a little bit more seriously. In terms of whether the patient's partner provides a reservoir of bacteria that keeps being handed back, that's a more tricky one to address because the guidelines are very strict. Additionally, the women with vaginal colonies of, and we see this all the time on vaginal swabs, vaginal colonies that mimic the bladder microbiome. So let's say we've got an E. coli Enterococcus Klebsiella patient. We so often find the 3 same bugs in their vaginas and a lack of lactobacilli. And this is something I do like to do with my patients to work out, you know, what is the point in trying to clean up their bladder when we have got a reservoir of bugs sitting right next door. Some patients' urethras are actually at the bottom of, you know, everybody's anatomy is slightly different, and some patients, you know, it's actually within the opening of the vagina, the urethra. So you know, they've got a colony sat all around them. So we do like to clear out the infection from the patient's vaginas as well, and then treat them with vaginal probiotics to, it's almost like cleaning out, you know, a house that's got squatters in and has been wrecked. So you chuck the squatters out, give the house a decent clean, and then put some nice tenants in.
Yeah, that's a good analogy. One question that comes up a bit is that given the bladder is not sterile and something like expansor culture is picking up more organisms, how do you know what's appropriate to treat and what might just be part of the normal biome?
Okay, well, there is, you know, we do have, you know, an extent of literature out there that tells us what the normal healthy vaginal microbiome is. And we are currently partnering with a molecular lab to a certain extent. We're doing some validation testing for their very accurate molecular testing. And it's very useful to actually run at least the vaginal swabs through the molecular testing, because we know that traditional culture does not provide enough information about anaerobic organisms. And due to the nature of the vagina, an awful lot of the natural vaginal microbiome is anaerobic. And so we do like to process through this lab as well to have a little look at the full extent
Mhm.
of the flora. In terms of the urinary microbiome, absolutely, we can do that as well. We can process through molecular lab to have a look at the full extent of the urinary microbiome, and we can just literally go through, friend, foe, friend,
Mhm.
foe. You can have a look at the breakdown of organisms and work out which is the friend and which is the foe due to what is out there in the literature, what is recognized as natural flora, and what is not. There is more work needing doing. It is in its infancy, but we're probably better placed to do that than anybody else.
Yeah. And when someone does have multiple potential pathogens show up on a test, do you sometimes have to provide multiple antibiotics to target those?
We prefer to try and keep things to single antibiotics, but if it is not possible due to the sensitivity pattern of the organisms, yeah, we do need to combine antibiotics.
Okay.
But we try to keep that to as short a time as possible. Of course, we monitor the patient's symptoms very closely, and we try to wheel back. And we see this, we've seen this time and again, whereby we have patients present with nasty multiple pathogens, and we go in good and hard for a few weeks with dual antibiotics, and then we'll peel away maybe one of the potentially riskier antibiotics. And we do find this once we get the acute multi-infection under control, we can actually pull off the accelerator. And this is one of the things where I find hyperx so useful to co-prescribe alongside antibiotics, because it covers all bugs.
Okay. There was one question I missed on the hyperx front, and that was, can you use it as a prophylaxis? So after sex or after another trigger event in the way that you would an antibiotic?
Yeah, absolutely, you can. I'd have to actually double check whether that's in the product license, but I can tell you now that I do with some of my my patients. So we have to be very careful, and sometimes the patients are incredibly, once they have recovered, they're incredibly anxious about falling ill again. It's said to be one of these illnesses that once felt, never forgotten. And if you've spent months or even years of your life feeling unwell with this, and suddenly your life is back and you aren't aware of your bladder and your sex life is starting up again, usually the patient will be asking for something. And so we will say to patients, yeah, absolutely, take a hyperx and take a teaspoonful of D-mannose powder to cover you, and make sure that all the lifestyle modifications, pee before and after sex, and maybe even have a bit of a shower beforehand, etc.
Okay. There was another question around the sterility of the bladder and how you could therefore show that there are no organisms present before surgery, which is something that a lot of people often have to go through. Is it even possible, and how does that make sense?
Right. Okay. So I don't think a bladder with no organisms at all present, because you're always going to have some healthy organisms there. But I think it's very important that if you have got symptoms, checking that there are no nasties there, so no uropathogens there, no UTI causing organisms there. And I think it's really important after surgical procedures that things are kept clean for when it's healing. Certainly we have experience of dealing with quite a number of patients who have had surgical procedures aimed at removing a lot of infected tissue within the bladder, especially when they've had this disease for years. And it can be an incredibly useful and successful procedure, as long as you make sure that you keep the environment of the bladder nice and clean whilst the patient heals. And indeed, bladders heal incredibly well from these procedures, but you don't want to infect your fresh new tissue.